So the time is now noon, so we can get started. Dr. Fingerhood, I'm going to stop sharing my screen, and then as I'm giving the intro, if you want to pull up your slides, you're welcome to. So the time is now noon, so we can get started. As you heard at the beginning, this webinar is going to be unrecorded. It will be available on our website within 1 week from today. But my name is Tracy Summer. I'm going to be helping to facilitate today's webinar. As I mentioned, today's webinar is hosted by MAX, the Maryland Addiction Consultation Service. And for those who are not familiar, we support prescribers and their healthcare teams across Maryland with questions about treating your patients with any substance use disorder or questions about pain management. And all of our services are free, including phone consultation for clinical questions, help with finding resources and information, a lot of education and training events, such as today's webinar, as well as our technical assistance to practices starting or expanding their office-based addiction treatment, our tele-echo clinics, as well as our Max for Moms program. So please feel free to reach out to us for support. On our team also is Marcielle, and she put our information into the chat, and you can call us anytime. Before we dive in, I'm going to quickly go over some housekeeping items and the process for earning credit for today's training. If you do have any questions during today's webinar, you can put that into the chat, and there is going to be time at the end for questions. As I mentioned, a copy of today's slide and the recording is going to be uploaded to our website within 1 week. In order to get CME or CEU credit for today's training, you must be online for the full duration, and you must complete the evaluation survey within 7 days from today. That survey will be available in your OASIS portal as soon as this webinar is finished, and you can log in and you can access that evaluation, and then you can download your certificate. I'm now happy to introduce our presenter first for today. So today we have with us Dr. Michael Fingerhood. And Dr. Fingerhood is a professor of medicine and public health at Johns Hopkins University, as well as the Division of Addiction Medicine Director at Johns Hopkins Bayview. His areas of clinical expertise include addiction medicine and internal medicine. He earned his MD from Albert Einstein College of Medicine of Yeshiva University. He completed his residency at Hopkins, and his research interests include substance use disorders, contingency management, Hep C, and HIV. He's a member of several professional organizations, including the Society of Addiction Medicine, the Academy Internal Medicine, and the College of Physicians. So thank you so much, Dr. Fingerhood. I know that that definitely doesn't cover everything that you do. And thank you for being here today with us to present, and I'm now happy to pass it on to you.
So thank you. So I hope that this is interactive. The beginning part is going to be just laying out mostly some terms, and the second half is going to be very focused on individuals. It looks like there's or people who have put their names and titles. It looks like it's a nice mix of people. This is not meant, and this webinar is supposed to be appropriate for everybody, whether you're a physician, a counselor, a social worker, no matter who you are. And I'm going to ask for participation. And your participation, even though there may be medical scenarios, doesn't depend on you being a physician or a nurse practitioner or a physician assistant. So I'm going to go forward. And you heard about the max. So these are the objectives: increase knowledge of biases. And I think all of us should reflect as we think about these as well. I often reflect, and we're in pretty tough times when we watch the news. So biases are definitely part of our lives every day. And to learn what to do when stigma arises. And I'm going to just say in the background to encourage to speak up when you see stigma arise. Um, And so think about why there is stigma in situations where stigma occurs and actually could have a negative impact on patient care. So these are going to be some terms, and some of these are nuanced and they're meant to trigger thought. So stigma, these are some definitions of stigma, even though we use that term a lot. A mark of disgrace associated with a particular circumstance, quality, or person. And that, so more in the realm of perhaps how we more commonly think about it, a set of negative and often unfair beliefs that a society or group of people have about something. Remember, that something is pretty non-specific. A strong feeling of disapproval that most people in a society have about something, especially when this is unfair. And then I think the most appropriate as we thinking about patient care, a strong lack of respect for a person or a group of people or a bad opinion of them because they have done something society does not approve. Some more words. Sorry. Bias, which is an inclination to favor or oppose a person, group, idea, or thing in an unfair, inaccurate, or prejudicial way. Right. So, and you probably know this, biases can be conscious or unconscious and can be held by individuals, groups, institutions, political parties. Um, Explicit bias and stigma greatly overlap, right? If you think about that definition of bias. And related is the term we often use of prejudice, right? So it's an unfavorable and negative attitude toward a person or group that's formed without good reason or prior experience. And then I added this year the positives, which we hope happen as a result of thinking about patients and patient care. And they're the two terms are empathy and compassion. And I want to point out that they're not the same. So the empathy is the ability to understand and share the feelings of another person, right? To see things from their perspective rather than your own. I think that's what I try to do. Hopefully, all of you do as you're interacting with a patient. Imagining what someone else might be thinking or feeling may lead to compassionate actions. So, but empathy it's unto itself doesn't mean you're doing anything about it, right? So compassion is the feeling of sympathy and sorrow for another person's suffering, combined with a strong desire to help relieve it. So, what the hope is that you have empathy, which leads to compassion, which then leads to an action. And as we go through some patient vignettes, we'll talk about what those actions could be. Now, some ethics. I sat on our hospital ethics committee for over 25 years. Uh, Saw many patients related that with a substance use disorder. And as one of the vignettes will be actually a patient we saw on the ethics committee. So these are some of the terms. And I think that you have to think about ethical principles as you're really trying to address stigma related to patient care. Uh, so autonomy, right? So autonomy says that patients have personal liberty and can choose their own actions. And this means that patients can, just like all of us, can make poor choices. I'm sure we can all reflect without revealing um, that we make poor choices or we do things that perhaps aren't the healthiest at times, but we have the autonomy to do that. And just think in the background is how there could be some limits on autonomy, and some of the patient vignettes will point that out as well. Uh, but there has to be some judgment by a clinician whether a drug is impacting decision making. So, is autonomy granted to someone who's intoxicated or under the influence of a drug? And I just want to point out that being under the influence isn't based on a level. So an alcohol level would not dictate whether or not someone can be autonomous for decision making. Beneficence, I think, is something that we should all be thinking about. And there's a term here which I think is correct, which is an obligation. And that term is a new word to think about. Obligation of healthcare providers to deliver a care to the full benefit of patients. And then I put, I believe, in parentheses, without stigma. And I think that the stigma should perhaps could have been without parentheses. And the use of shared decision making. Justice requires the absence of stigma. So a lot of philosophy here in ethics mandates that patients with substance use disorders are treated as any other patient should be treated. And I want to point out that that is true under the American with Disabilities Act. And for instance, I in my battle for justice for people with addiction, uh, 2 years ago, as part of a legal case where I submitted a legal brief for someone who was incarcerated in West Virginia, who was denied continuance of buprenorphine for opioid use disorder, and we won the case based on the American with Disabilities Act. That you also cannot discriminate against a complication based on its cause. Uh, and that means that if there's a complication that can happen from a substance use disorder and from other things as well, you can't decide whether or not you're going to treat someone uh, based on the fact they have a substance use disorder versus the fact perhaps their wound is related to diabetes. And it's an obligation that providers advocate for their patients with substance use disorder. So again, advocacy is important and it's required, helping them avoid discrimination and assisting them in accessing services and treatment they need. Now, futility is most often invoked incorrectly. So medical treatment must be evidence-based and not based on personal experience, devoid of stigma. So it is not correct and I've seen this happen many times, for a person to say, well, in my experience, uh, a person who has this infection shouldn't have surgery because I've never met someone who stopped injecting drugs. Um, right? That's not that is totally void in the realm of futility. That you often have to weigh autonomy, beneficence, and justice against futility, and especially as I mentioned in inpatient settings, we really require that futility be assessed using a multidisciplinary team. Um, and usually it's medical physicians, nurses, social workers, legal, lay, and religious representation, and we discuss it together. So what about more specific um, facts related to stigma and addiction? This is a study published in the Annals of Internal Medicine. 75% of primary care physicians would not want a person with opioid use disorder to marry into their family. Two-thirds of these physicians viewed people with opioid use disorder as dangerous. In a study that I did, 54% of ED providers prefer not to work with patients with substance use who have pain. Um, Communities are leery of treatment programs. Um, Zoning laws trying to prevent treatment programs, but not prevent liquor stores. That's my editorializing. Um, Makers trying to pass bills limiting treatment. There's currently a considered bill in the Baltimore City Council looking at creating zoning laws in order to prevent more treatment. We have enough. A city council person uh, about 3 weeks ago said we have enough treatment programs in Baltimore City. We don't need more. Um, Many housing and recovery programs do not allow individuals to be on medication for OUD. Again, that is a violation of the American with Disabilities Act. Narcotics Anonymous meetings most often do not allow someone on a medication for opioid use disorder to speak or chair. And this all goes in the background. And this has been true for, for definitely over 50 years, that the general view of addiction is a legalistic moral view, and that people who use drugs are bad people, and incarceration is the answer. So what are some of the answers to stigma? During the discussion, I welcome you to think of your answers. So use of person first language, we'll talk about education about addiction. We need to do a much better job educating the public that medication and treatment works. That medication for opioid disorder is not substituting one drug for another. We need to humanize people with addiction. And part of that humanizing people with addiction, I found over the last 15 years, has been use of peer recovery coaches and community health workers in medical and non-medical settings. This has had, most importantly, it's had a dramatic impact in emergency department settings where most of the emergency department staff exposure to people with addiction has been purely people who they say, oh, so and so's back again. Terrible terms like that's a frequent flyer. There's no hope, right? But as I pointed out, I took care of a patient who had come through the emergency room 17 times over about a 4-year period for treatment for alcohol withdrawal. And then I remember reflecting with him after he was sober. Um, he said, he reflected that, I haven't been in the ED, and the ED doesn't know. So they assume if that person doesn't come back, that perhaps something bad happened to them. They didn't realize that people don't come back because they've achieved some recovery. And peer recovery coaches in the ED have changed that. All of a sudden, there are people with recovery who are working side by side, and in that setting, people know that there is some hope. And thank you, Steve Davis, for that comment. Um, so can we impact stigma related to addiction? Uh, so this was a study we published 3 years ago, and I'm going to show you, we created after this actually a campaign to try to impact stigma. And it was really looking at focus groups where we gave messaging uh, ranging from a Words Matter campaign, which I'll show you, that emphasized the harm of stigmatizing language, and another one on the effectiveness of medication. And there were messages, there were some visuals, um, and there were some narrative vignettes as well of patients who related how they had done. Um, so the bottom line was that the messaging and the campaign had an impact, and that if we make these efforts, including a webinar like this, and we touch enough people, that we can impact. Now, for all of you who are attending this, I think that I'm preaching to the choir, but so it's now going to be up to you after this to actually spread the word to all the people that you know, and to speak up when you see stigma. So this is the anti-stigma campaign that we created here at Hopkins. Um, and you can see it's meant to, at first people, they were going to use real patients, but they weren't real patients. So we used caricatures instead. And again, it says, what we say and do matters to patients with substance use disorder. Um, and again, you could go online to see the campaign. Uh, and it has information about stigma, what causes stigma, has resources, words to use and not use. I'll show you that in a second. And some facts about medication treatment. So these are some of the terms that I hope that you're aware of already. Substance use disorder, addiction, person with substance use disorder. Now, having said that, I just want to point out that, for instance, the term on the left, addict, for instance, people who in recovery and go to NA meetings introduce themselves and say, "Hi, my name is Bill, and I'm an addict," um, and and that's different, right? So they're in a setting where they're self-using that term. Having said that, I do believe at times people with substance disorders can be self-stigmatizing. So um, I think it's important to be careful, but I think that in a safe setting, that's a little bit different. But for all of us, we should use the preferred terms, and you can see um, the other one that I always correct that patients use is clean and dirty. If you, for those of you who have heard me talk before, the dirty urine means that you have an infection, um, and that if you're clean, it means you took a shower. Um, so I encourage patients to talk about being in recovery. And then we need to get away from terms like for when we have patients on buprenorphine and methadone, substitution therapy, replacement therapy, or medication assisted treatment, because it's the medicate. We don't say for someone who's diabetes and they're on medication assisted treatment, right? They're on medication and they have to exercise and eat healthy, much the same for someone with opioid use disorder. This is the campaign. We have a pledge that's still active. Look at the time. So I'm going to go quickly. So options for opioid use disorder treatment are really medication for opioid disorder. We're really just going to discuss methadone and buprenorphine briefly. Naltrexone, I have nobody on naltrexone, and concern that, in fact, that naltrexone in the 2025 can cause harm. Someone stops taking it, they lose their tolerance, they go back to use what they used last, and they overdose and die. Simple detoxification and no other treatment, again, doomed for failure and increased risk of overdose death. Counseling and support without MOUD for most patients in 2025 uh, is not effective. Lots of studies, I'll show you one in a second, showing the impact of not using MOUD and referral to short or long-term residential treatment. And certainly that could be used in combination with medication for opioid use disorder. So the goals of pharmacotherapy, I just want to point out really, early on, we want to manage withdrawal. And then really what we're trying to do is reduce drug use and have a sustained reduction or abstinence. This is especially true for someone on buprenorphine. Just realize that when we start these medications, people, it's not an on-off switch. People will still occasionally use. The majority of people will still use, especially the first couple of weeks. But especially for buprenorphine, as the buprenorphine is in their system and they use, they're not going to die of an overdose. Um, and then over time, we want to be able to improve people's lives, manage all the physical and social complications of opioid use as well. These are the medications. I'm going to go through, I'm just going to skip this. Um, and this is really one of, this is a study published by Mark LaRochelle, who I had dinner with just by coincidence 2 nights ago, who's up in Boston, published in Annals of Internal Medicine. And it looked at cumulative incidence of all-cause mortality at 12 months from a non-fatal overdose. And you can see medications, or especially the numbers of people on naltrexone is really small. So I'm going to exclude that. But you can see that no medication for opioid use disorder versus being on methadone or buprenorphine, tremendous impact on mortality. Again, buprenorphine is a partial agonist. It has high affinity. We worry about, especially in the age of fentanyl, that generally we introduce it at really low doses to start. I do it in a low threshold setting at a church all the time with a lot of coaching of people starting off really slowly. And if people have to use, I tell them it's okay to continue to use, but keep on pushing ahead with the buprenorphine. And we do the same thing actually in the inpatient setting, that we often continue a full agonist while we're trying to build up levels of buprenorphine. It is true that in 2025, most often go to higher doses of buprenorphine than I would have 5 years ago. So it's not unusual for most people are on 24 to 32 milligrams. Methadone, uh, until the MODA Act is passed, patients still will have to go to a methadone program. Methadone rules are still antiquated. In the hospital setting, we go introduce methadone much more quickly in the setting of knowing that patients are using enormous amounts of fentanyl. Um, uh, I'll just point out, giving someone methadone 30 milligrams to start means they're probably getting less than 1/10 of the amount equivalents of opioid if they're using fentanyl 6 to 10 times a day or 6 to 10 pills a day. So it'd be nice if we had more than two really effective medications, but I individualize, as I discussed with patients, methadone or buprenorphine. I'm going to flip over that. So what about medication stigma and peer recovery? So I mentioned earlier, the individuals using medications face stigma and peer support settings, which could be contradictory and counterproductive. And we did a study, as you can see, published in, what year was this? 2018, where we created a meeting called AIM, Ability, Inspiration, Motivation, specifically for individuals that were going to be treated on buprenorphine. We did this actually at Dee's place, which unfortunately is closing next week, really sadly. But Dee's place, I've been involved with for over a decade as a recovery site where we had to win over people who were uh, fully 12-step involved and initially wouldn't allow, as I mentioned earlier, individuals on buprenorphine to really speak at meetings, even depending on the meeting. So we created these specific meetings where people on buprenorphine or methadone could speak. And in speaking with the people on buprenorphine methadone, they definitely felt stigmatized. Okay, now we're going to shift to um, interaction, and I welcome people to, on their own, to come off mute and to interact. These are all, there's three of them, and then I'm going to ask participation for you to all introduce your places where you've seen stigma and whether or not you spoke up or your scenarios are certainly welcome. So this is a 34-year-old woman, former preschool teacher, admitted with a fever at 104, a large painful leg abscess, drained in the emergency room, being treated with intravenous antibiotics. Second day of treatment, announces she wishes to leave. Should she be able to leave? Somebody has to be not shy, and you don't have to have a medical background to think about whether or not. So, and I just want to say that we also have changed the language of someone leaving. We used to call it against medical advice, and the preferred term now is self-directed discharge, um, because uh, uh, the against medical advice has a different meaning. So someone said, "You man allowed legally." I guess yes, because for instance, if some people have argued, there was a piece in JAMA about 15 to 20 years ago where a physician argued that this person legally should not be allowed to leave because in the same way that someone who is suicidal with a plan shouldn't be allowed to leave the hospital. So Ann Sawyer, I'm going to say that I'm going to say yes, legally should they be allowed to leave. People can speak up too. I see. I'm looking, glancing at my other screen. Um, yeah. So
Yes, she should be allowed to leave. She's got those rights. Although one can argue that she's making decisions which are affected by her addiction in the same way someone who wants to commit suicide is affected by their depression and therefore lacks the capacity to make a reasoned judgment. That's an argument that people use.
great answer. Right. So in the background, I mentioned earlier, do patients have the right to make a quote bad decision? I think the answer is yes. And it's interesting about, I don't know, this also on the ethics committee days, there was a patient in the sitting of a day after having a heart attack, wanted to leave the hospital to smoke. Um, and there was obviously frustration with that patient, but not the same way, right? Somehow we think of someone who wants to smoke differently than this person. Uh, and so that I'm reading the other comments. She's about to leave, offer prescription antibiotic. I agree with that. So, in fact, we do everything we can to try to have a favorable outcome. So we're going to go through her a little bit more, but I totally agree. We would do everything we could to try to maximize success if she leaves. Now, historically, I remember not that long ago when the teams would angrily say, "Okay, just sign this," and that would be the end of it. But right now, right, if this patient, we're going to talk about trying to get her to stay, but we would do everything possible, hopefully in 2025, to make sure that even if she left, that she has some chance of doing well. Um, And we do think that if she leaves, that she could have some harm happen. Um, and then we asked, so what would facilitate her staying? And someone offer medication for withdrawal, and right, and offer, why do you want to leave? Oh, to understand, right? So she has a large painful leg abscess, right? I haven't told you whether or not she's getting anything to alleviate her pain. So I'm going to shift to the next slide, right? So she states she's in pain and wants to leave in order to use. Um, and her care team does not prescribe opioids for pain because she is already addicted to them, right? So Steve Davis said, first seek to understand. Absolutely right, right? That's what we're going to do here, right? So why do you want to leave? What can we do to help you stay? And to understand, right? First seek to understand. Having a peer involved. I agree with that too, Catherine said. Um, why was MUD not offered? That's correct too. So I see a nuance of this situation every week that I'm on consults, and I'm on consults every 6 weeks. So literally 3 weeks ago, I on a Saturday, I got a message about a patient who wanted to leave. We don't understand. She's on methadone. She had like this patient a mass a abscess, and there was a note in the chart. She's on methadone, and therefore she doesn't need pain medication. And this is the same I thought here, right? She's using opioids, so why would she need pain medications? Um, or why would I give her something that will contribute to her addiction, right? So there's a misbelief of this patient. So so the first thing we would say to the team is what we want to understand, as all of you have said. We want to alleviate her pain, right? If she didn't have addiction, we would be giving her pain medication and a discussion, as Ann Sorry said, to think about offering MOUD. And in this instance, we're a little bit limited. I put which one. This is perhaps more medical than it needs to be, but because she was needed opioid agonist, that uh, we could say to her, we have a choice. We can just give you adequate pain medication and help make sure you're not in withdrawal. If she was interested in buprenorphine, which we wouldn't be able to do as alleviate her pain as well, or we could give methadone now for MOUD and give additional medication for pain, and then often be able to defer. It's not unusual for someone to decide during their course that they want to switch from methadone to buprenorphine once the medical complication causing pain is improved. Okay, so she started on hydromorphone, which is brand name is you may know is Dilaudid, PRN for pain, and I'll talk about that in a second, and methadone for opioid use disorder. But the next day when you return, she tells you that she decided she doesn't want to be on methadone, as her mother told her she needs to be in treatment, but not on that stuff that makes you a zombie. Now I hear this all the time. So this probably happens, in the week I'm on, we probably do about 20 consults. Probably at least one of those 20 consults, this scenario plays out. You also learned she's not receiving any hydromorphone despite reporting significant pain. Okay, and then I'm asking you to read my mind a little bit. I agree with Catherine's comment. So why is she not receiving pain medication? Anybody? Because it's stigma, right? So it's easier to say that stigma. So as a resident, probably a decade, pointed out to me that very often for patients with addiction, you know what PRN stands for? Patient receives nothing. So for addiction, PRN doesn't work as it does for other patients. So usually we recommend from our consult service is to write for standing doses, to administer a pain scale, and the choices of dose are based on pain scale, but there's no such thing as PRN. Understanding that patients can refuse if they don't have pain. Um, yeah. So Michelle Green said many times patients don't understand they should ask for PRN pain medication. But I fear that I think that's true, but I also fear the other side as well. So having some standing orders as well, or a combination of standing and PRN is important. And we do emphasize if there are PRN orders to be for patients to know they can speak up. But PRN is often difficult, especially as to defend the nurses. Their patient to nurse ratios are often unsafe, and it's difficult to give a PRN pain medication in a timely fashion. So I agree, Sadie. And then how do you respond to her new reluctance to be on methadone? Um, it's tough, and sometimes I ask for um, when is your mom going to be here to see if we can meet at the same time. And there really needs to be a lot of education. There's a lot of family pressures against MOUD that are sometimes difficult to overcome, but having a conversation um, and education of the family as well. I mean, they must know that at some level they've seen their family member really suffer and have negative complications. So education about medication really having an impact in terms of preventing overdose and stabilizing health is an important message. I'm going to go on to the next. By the way, this patient um, did stay on methadone. We did have a family meeting, and she wound up doing well with good language, uh, peer recovery coach working with her, linking her to a treatment program, and we know that she continued on methadone at discharge. We also have a great program now where we do methadone for home. Uh, I'll just say as a separate, really big plus. Um, for instance, if someone goes home on a Friday and their intake is Monday, patients can go home with their methadone, up to 3 doses of methadone. This is a patient I met on the consult service uh, about 15 years ago. So this is a 28-year-old woman, mother of two girls, 3 and 5. And I always put in a background. Too often when I read medical histories, they're always negative histories. So I encourage everybody as you try to describe people with a substance use disorder to humanize them, meaning their vocation. A mother of two girls, 3 and 5, is my way of doing that. Past history of injection drug use in the emergency department with chest pain. She had finished treatment for aortic valve endocarditis 3 months previous, doing well on her methadone program for opioid use disorder. And evaluation, I'm going to try to explain what this means. An ascending aortic dissection originating at the aortic valve. So it was a complication of her aortic valve endocarditis. She had some separation, and she now had a false lumen, a dissection, meaning that she had separation of the aortic wall, and she had blood flowing both through which should be the true inner part of her aorta, as well through the wall, which put her at risk for aortic um, catastrophe, meaning uh, uh, um, full opening of aorta leading to catastrophic death. With the emergency need for surgery, meaning she needed a repair of the aorta with a new graft wall. Cardiology is contacted, but the cardiologist believed that the patient should not be considered for surgery, as this would be futile care for a patient with addiction who would not be adherent to anticoagulation medication after surgery. So she would need to be on blood thinner. This is about 15 years ago. We didn't have direct oral anticoagulant. She would have needed to be on warfarin with blood monitoring. But this woman essentially was pre-CPR, right? So when we do CPR, we don't think, should I start CPR in this patient? Because if they make it, I don't think they're going to be adherent with medications they might need for permanent heart disease. We don't go into those thoughts, right? But just think about the fact that this cardiologist believed that this woman who was going to have imminent death without surgery, that it was futile to refer her for surgery. Now, I just want to point out this is not referring someone for a transplant or a limited resource. Uh, that's a different topic I'm not including today, um, but rather having just surgery, a well-described surgery um, that people without addiction have aortic dissections as well. And I don't think there's any consideration in someone without addiction as to whether or not you should do surgery for aortic dissection. So this was clearly a case where stigma had inappropriately dictated someone's belief that a treatment was futile. Um, so what do you say? So um, it was 100% stigma. And in a way, it was unfortunate that the cardiologist had never claimed that she had never met somebody who had recovery from opioid use disorder. So it's shocking to us, but this was real. So it
Can I
illustrates.
ask?
Go ahead.
Sorry, can I ask a question? And
Absolutely.
how could the provider assume that the patient was not going to be adherent to the anticoagulant? I mean, I don't understand how they could make that assumption. She was stable on methadone, it says, so she was
Correct.
stable with her treatment plan. She had a past history, but I feel like this is just 1000% stigma, but how could they make that assumption? And I know for a fact, if it wasn't a patient who had any history of addiction, they would treat them differently.
Correct. Now, I made it, this is the true scenario, but I'm going to argue that, say that she had presented with aortic valve ectodermatitis and right away had a dissection, that the decision for surgery should have been the same anyway. Just so happened that this made it even more glaring, perhaps, because in fact she had been doing well. And I'll just say this: that her mom was actually, believe it or not, in the emergency room waiting room with those two kids. Um, it was really emotional for me to be able to see uh, this type of situation and the human factor of who she was and the attempts and anyway. So I just, but this is a true scenario. So we were able to actually um, it was a Friday afternoon also, which I remember being here late, to win over and get her emergency, someone at Hopkins Bayview. And we were able to somewhat with use of emergency department people, get her directly to cardiac surgery, kind of bypassing the cardiology evaluation. Um, so we had to go around the person who was providing stigma to her. Um, I remember feeling really, so I hope all of you feel really angry. I was really angry. And so these situations bring out emotion as well. And trying to contain emotion, but knowing that you have to commit to justice for our patients. And you remember all those terms I used earlier, right? So part of our aim for justice is we're often the most important advocates for our patients. And when we see this type of situation, we have to do everything we can to advocate for justice and overcoming stigma that is clearly can be incredibly negative towards. I mean, this woman would have died, I think, if somehow, as an ethics committee, we hadn't gotten involved. So there's a comment, peers could be the voice for the patient. Yeah, this was about 15 years ago before we had a lot of peers around. But I don't, so even if there was a peer involved, I don't know if a peer would have, I hope they would have, but I don't know. So it's, you either could put yourself in a peer's shoes, how much you could speak up in this realm. I hope that they would, but it's not easy. One more, and then we're going to shift to yours.
I
Um,
have a
go ahead.
comment.
Go ahead.
We will have intervention with the patient because we have access to what's going on. Just to step in as a voice for that patient, we have to reinforce, other underlying problems that coexist before the patient is, having a heart issue, that these things don't change the person. The
Yep.
heart is the issue at that point,
Yep.
not the MOUD.
Yep. What role do you have, Catherine?
I'm a peer recovery specialist
Oh,
at John Hopkins, Howard County.
got it. Wow. How many peer recovery coaches are there at Johns Hopkins Howard County now?
Myself and one other.
Well, thank you for doing that. How long have you been there?
We've been embedded here now probably 5 years.
Well, good for you.
I've been with the health department for 11.
Got it. We're trying to have an addiction medicine consult service at Howard County, and I won't say who, but initially the response was we don't have a need for it.
Oh,
Um,
we get pushback, trust me. And
okay.
I'm not afraid to find other sources.
Well, it's great. I'm gonna remember your name because I may want to contact you.
Thank you, sir.
Thanks. Thank you for everything. Um, because we even, we have naloxone in hand, and we've had that at Hopkins Hospital, Hopkins Baby for a long time. And the initial response at Howard County when we first wanted it to happen was, we don't need it here. So thank you for your efforts. Um,
Yes, we do.
I know.
I have
Um,
numbers to prove it.
thanks. So this is a 24-year-old artist. This was my patient. Started on buprenorphine 4 months ago. She's doing well. First time on MOUD. Started using opioid pills as a teen, and this is the longest she's ever gone, not using quote street opioids. Her current visit, she asked to be tapered off buprenorphine. She went to an NA meeting where she was told she wasn't clean. Lots of bad stuff there. So, uh, how do you respond? So, no, at this point, nobody should be shy. So, what do you say? Anybody? Catherine,
I
thank you.
think maybe start with,
Go
oh,
ahead.
sorry.
You
I was
go
just going to say
first.
maybe start with asking her why she wants to be tapered off. I understand the incident happened, but trying to understand the mindset
Yeah,
initially, that would be my thought.
thank you. Someone else?
How about I have medication assisted treatment for my co-occurring disorder. Is that not an example of I take it as prescribed and it's not mood altering.
Yeah.
Therefore, you know, it's use or die.
Yeah, this isn't meant to say AA is better than NA, but AA, Alcoholics Anonymous, if I'm using that term, has also always said that a medical professional prescribes you something for your health, that you're allowed to take it, whether it be for mood or anything else. Um, Yeah, and but yet that still hasn't changed within NA. Anne pointed out stats about doing better if you stay in MUD for longer. Um, yeah, and especially because street drugs are stronger, and especially if she had a return to use, that could be disastrous. Um, I have some, I can't say how many, but some number of my patients on buprenorphine. I have probably 150. At some point, stop going to um, regular NA meetings because they're tired of people. They're saying things about medications. I do know from patients there are some 12-step meetings that are more welcoming to people on, and I mentioned the AIM group that we created. And the message there, that's why AA attendance has risen. I do have a lot of patients on MOUD who go to AA for their support, just because they take the message and they feel that they can use all the feelings expressed at an AA meeting in a better way because the negative statements sometimes made about methadone or buprenorphine aren't there. Yeah, and contributed that I know people who were told to come off psych meds at 12-step groups. Um, yeah, so I mentioned Steve Davis that if someone is taking buprenorphine and they do use that they're not going to have an overdose. If they and I usually say that I don't want to say you're going to use, but if you have a brief return to use, if you have vulnerable moments, um, uh, uh, if there's something that happens that tests your coping skills, um, that you're okay. And I don't use your this is off topic. I don't use urine toxicology or urine drug screens very much anymore, but occasionally early on I'll use them. And if someone has both fentanyl and buprenorphine in their urine, I usually then say, look, it looks like you had a slip. Thank God you're on buprenorphine because it probably saved your life. So thanks, Steve Davis. Any other comments? So someone pointed out that this is a little bit off topic, but one of the forms of injectable buprenorphine. Occasionally, if someone wants to come off after for a few years, we use injectables to help them taper. Um, Again, off topic, injectables are something to think about. Sometimes injectables, this is kind of beyond what I wanted to mention, but sometimes injectable buprenorphine helps with self stigma, meaning that if you take a medication every day, you they self stigmatize every day. But if you get an injectable buprenorphine, the other days the other 29 days, you're not applying stigma to yourself relating to being on buprenorphine. Yeah, I think it is helpful to help sick patients know how to respond. And you should, I coach into patients. Like I asked them, are you going to be going to 12-step meetings? And rehearse, I agree with Amy to be able to say, or rehearse with patients, what are you going to say? How are you going to react? And to let them know that this may happen so that they're not shocked or dismayed at the point of someone saying something like that that's inappropriate.
I have a question. It's not completely related, but
Okay.
somewhat related with the medication portion of this. So, for those patients who are coming in and they're wanting to say stop using, but they're fearful because they're afraid of being put in precipitated withdrawal if like a Suboxone is prescribed. I mean, yes, there's other medications, but some providers are just very hesitant to prescribe like a methadone over a Suboxone. I think changing that mindset is important as well because then patients are fearful and they know because they've likely been there before and they're like, I don't want to go into precipitated withdrawal. That's worse than regular withdrawal.
Yeah, so I always have a discussion about precipitated withdrawal, and what history they've had, and but you'd be surprised. I take care of patients who unfortunately have had some brief returns to use, and who are really good about getting themselves back on buprenorphine even on their own, knowing that you build up the doses really, as I mentioned earlier, you know, you can't do this in the hospital, but I can prescribe someone an 8 milligram film and tell them to cut it into 8 little pieces and take a tiny dose. Excuse me, and if they have to use, it's okay, but continue every hour or two taking in one of these tiny pieces. And I'd say over 90% of people I get onto buprenorphine doing that. Okay, so last, I don't know, 5 minutes. Uh, Anybody want to share? Or I'm putting someone on the spot. As a peer recovery specialist, what do you say to individuals about accepting, for instance, medication for opioid use disorder? If you see someone in the emergency department, perhaps who's had an overdose.
Well, you have to assess their level of willingness to even engage in treatment at this point. Um, you, you may, and I often find this, they are so distracted by the withdrawal symptoms themselves that they're feeling that hopelessness and helplessness. And introducing them to this other pathway, um, it you have to be there and support them, more than an hour. This may take several hours over the course of a day.
Yeah. I mean, you use the term right. You have to assess hope, right? I think that's really important. I usually say that to patients that what do you hope for? Um, yeah, and obviously in the background, realize the greatest risk factor for a fatal overdose is a previous non-fatal overdose. That's why that graph you saw was looking at people who had had a non-fatal overdose. How many of you, anybody else want to share an anecdote of when they spoke up, when they witnessed stigma?
Dr. Fingerhood, I'll share our county's experience kind of on a little bit of a larger scale, speaking up. I'm from Cecil County, and this is also a testament to the benefit of working with Max. We were hit pretty early and hard with xylazine and noticed and started observing, especially in our harm reduction programs, clients with really severe wounds, many of whom expressed disinterest in going and seeking care from our local hospital because of how they've been treated in the past. And fortunately, we had a peer program embedded in the hospital for many years, had good relationships with leadership at the hospital, working with Max, and the leadership at the hospital brought up some education and some programming, which resulted in a real significant shift in the treatment for opiate use disorder that was available in the hospital, much more assertive withdrawal management, as well as the beginning of MOUD induction inside the hospital. And these things have happened, and we've noticed now a significant change in the perception of our local hospital by the folks that we serve.
Yeah, as an aside, I was on an inpatient unit 2 weeks ago. So we take care of a lot of patients who come down from Cecil County, especially
Mhm.
from Fort Deposit and Elkton with medetomidine withdrawal,
Yep.
and really complicated withdrawal that we try to prevent them from going to intensive care. But
Yep.
um, yeah, so I find individuals, especially one gentleman I took care of, we became friends. I've checked on him. He's linked to treatment as well. So thank you for yeah. And with wounds related, there's also bias against people who have wounds. I alluded to earlier. Wounds are, from diabetes versus wounds from xylazine, which it doesn't. Those wounds don't necessarily happen where people used or injected. Uh,
Hmm. Yeah.
and we need to take care of people regardless of what the etiology of the wound was.
Well, I'm forever grateful for the providers we use for inpatient, outpatient treatment. I have a wonderful provider that specializes in wound care now. So it's a warm handoff all the time. As long as they're medically cleared, but still have a wound that needs to be taken care of, I can get them bed to bed.
Yeah. Ann Sawyer, where are you that you're seeing medetomidine? She's still here. I saw the comment. Oh, Ann's still here. Yeah. So someone else in Baltimore said, yeah. So the using every 4 hours is probably the medetomidine, and you're correct that it's been on Eastern Shore. I know in Easton in February, there was a point where all the ICU beds at the hospital in Easton were taken up by people with medetomidine withdrawal. Yeah, and someone said they buy in Penn North. So the last mass overdose events was a medetomidine tainted fentanyl. There have been three of them. But the one before that was related to a benzodiazepine that had tainted the drug supply. Yeah, and again, trying to treat people without stigma. So in terms of stigma, medetomidine means that we had to do a lot of education because a lot of the patients wind up in the intensive care unit needing a drip of a medication, which is Precedex, which is related to medetomidine. And we went in and we educated to prevent stigma, went in and educated the nurses and the physicians in the intensive care unit about treating a medetomidine withdrawal and that we will help co-manage. And so you need to preventive work for stigma as well, because all of a sudden patients with addiction are going to be in settings that they necessarily had not been in with this um, at this volume previously. So there's preventive stigma as well. Any other comments? I thank everybody.
Is there, oh, I'm sorry, is there a question, a tox screen for
There
medetomidine
is
yet?
not. So that's a great question. So the medical examiner looks at postmortem, but we actually have a medical toxicologist here at Hopkins. So we send them a chat message to specifically look for medetomidine in patients where we suspect it.
Right.
Um,
Because we provide the xylazine test strips
that's correct. But
and the fentanyl, but we're not jumping over to that new
yes,
leaf yet.
so you saw there are test strips. That's correct
Mhm.
for medetomidine. They're even available on Amazon because I remember I looked.
No
Uh,
way.
yes. So both xylazine and medetomidine test strips are available.
Thank you so much, Dr. Fingerhood. As
Thanks, Trace.
always,
Thanks,
absolutely
everyone.
wonderful presentation, and thank you for everyone for joining. We do have another minute. If you have any other questions, you can raise your hand or you can put it into the chat. And then I will also just go over again You can log into your Oasis portal now and you can access your evaluation. That does need to be completed within 7 days in order to access your CME or CEU certificate. After 7 days, it is going to close. If you have any issues trying to get in to it or any problems, please don't hesitate to reach out to us and we're happy to help. But I know we are at time at 1 o'clock, but if anyone has any other